morning, I'm Christine Kulstad from the University of Texas at Southwestern, and we're going to talk a little bit now about the SLOE. It was a nice lead-in from the last lecture, so we can talk about when you're doing your rotations, what is this piece of paper that is so important. First of all, some people will say SLOE, other people will say SLOE. I say SLOE, that's the right way to say it, but you'll hear both on the application process. So what is it? It stands for Standardized Letter of Evaluation. Back in my day, it was the SLOE, it was the Standardized Letter of Recommendation, and it was more modeled on the traditional letter of recommendation. It was supposed to talk about your good qualities. What it's moved into is to be a comprehensive assessment of your qualities as a potential emergency physician, comparing you to other peers in the field. So unfortunately, you don't get to be compared to that student who's going into pathology and is afraid of actually talking to patients. You're compared to other emergency medicine applicants. So like I said, it was developed to be discriminating or discerning. So when someone is applying to residency, it's really hard to compare a student from one institution to a student in another institution. Every institution has a different grading policy, different clinical schedules, different rotations, and then you get these general traditional letters of recommendation that all say really good things about everyone. And it's hard to know, like, are these students exactly the same or not? So the Standardized Letter of Evaluation was developed to try and help make that a little bit more clear-cut. It is supposed to be standardized, and because we're emergency physicians, it's very concise. It's easy to read. Only emergency medicine faculty can fill out a Standardized Letter of Evaluation. Do you need a SLOE? Yes, 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 you need a SLOE. You need a couple of SLOEs. This figure here is from a survey that's done every 2 years of program directors in emergency medicine. It's actually done of all program directors, but this graph is for emergency medicine. It asks the program directors to rank what they consider to be important in determining which applicants they'll give an interview to, and then to say, like, which ones do they look at and how important are those factors. So you'll see the second one there is the letter of evaluation in your field, which for us would be the SLOE. And it ties with step one as being most important in terms of people who look at it, the number of people, and then when they rank it with a weight, it's the most important factor. So this is a really, really, really important part of your application. How do you get a SLOE? As mentioned before, you're going to get one in your home rotation if you're lucky enough to have a home rotation at your institution. If not, you're going to get one from 2 away rotations. When you do an away rotation, you're supposed to get a SLOE. So if I see from your transcript that you've done 3 away rotations, but you only have 2 SLOEs, that's a little bit of a red flag. Did you go to that 3rd place and you really bombed it and you're thinking, oh, I'm just not going to submit the letter for this one? We're going to notice that, and that's going to be a concern. It's not a traditional SLOE, but you can generate a SLOE variant from these like other EM taught rotations like toxicology, ultrasound, or maybe wilderness medicine, critical care medicine. Those are not going to be as good, but it's something you can use to round out the rest of your application. These home rotation, away rotation SLOEs are generally written by a group. So when we're getting ready to write the SLOEs for that year, we get together as a committee and we review all the applicants, all their end of shift evaluations, their test scores, and then we write a SLOE. Those are the most valuable kinds of SLOEs when you're looking at a bunch of applicants. You can technically get a SLOE from an attending that you worked a couple shifts with and seem to really get along with, but those are not regarded as valuable because it's not done by this consensus of educational leaders in that institution. All right, is everyone still with me, still paying attention? So what's on the SLOE? It's divided up into 5 different categories: facts, details, qualifications, global assessment, and comments. And we'll go through each of those in a little bit more detail. Okay, first the facts. This part's pretty straightforward. Your name, your RSID, that sort of thing. How long have you known the applicant? So when you're doing an away rotation, that'll just be 1 month. And then how did you interact with the student? So if it is just an advisor who's writing you a SLOE who's never seen you clinically, that would be very obvious from this first part of the application, and the letter is not going to be really viewed as valuable at all. Then some of the details. Did the candidate rotate in your ID, your ED? Again, this should be a yes, otherwise it's not really a valid letter at all. What grade was given? Pretty straightforward. And then what number rotation was it for you? As mentioned before, you should be getting better on each EM rotation. So if the first rotation you got a pass, no big deal. Maybe you're just learning the ropes. Second rotation, you got to pass. Third rotation, you got to pass. If honors is available on that rotation and you're not getting better as time goes on, it can be a little bit of a red flag. This next box, let's see. Does this work? So over here, it has the percent of people at your institution who get those grades. You may not know this. Some rotations are pass-fail. Some rotations use all these different categories. Some use maybe just honors pass. So when we're looking at SLOEs and trying to compare one to the other, this part is really important. Also, different institutions give different percentage of honors if they do give honors. It may be 60% honors, it may be 10% honors. So when we see your grade, it's really helpful to know like how tough is this place at grading. And how many people rotated through that institution last year. If you go to a community program and they only have 20 students a year, the discernment ability of that letter writer is going to be less than if you're at a place that has 200 students a year. They just have a lot more comparison. Next, the qualifications. We're going to talk about this in a little bit more detail a little later in the talk, but basically you're taking all these different characteristics and saying, is this student at the level of their peers, above or below? The last two questions here ask, so when they're in residency, how much guidance do you think they'll need? Again, at the level of their peers, more or less, and if we give them that guidance, which we should because that's our job in residency training, do you think they'll do well? I do want you to notice, we ask, do you think they'll be outstanding, excellent, or good? So if you're in the lower category here, we're not saying you're bad, we're saying you're good instead of outstanding, and that does carry through to the other categories. And the last thing, the thing that's most important, if you're really just trying to run through a bunch of, like screening a bunch of applicants, you may just look at this area, is your overall global assessment. So it's divided into two parts. The first part asks, compared to all the students that you had last year, is the student in the top 10%, top third, middle third, or lower third? And then really important again are these boxes. So when all the students you had last year, how many students did you say were top 10%? When we started doing these, there was a lot of grade inflation. So you'd have, I had 100 students last year, 40 of them were top 10%, another 30 were top third. And it's like, well, that doesn't really work out math-wise. That's getting better, but it lets us know, like, again, how strict a grader is the person who's writing this letter. And then how many letters did you write last year? Again, if you wrote 4 letters last year and you say this is the best student I've ever seen, well, it just tells me that they're the best of 5 students versus I did 200 letters last year. The last question asks, on the rank list, where would I put this applicant? Again, top 10%, top third, or throughout that. You really hope you don't get unlikely to rank. We don't use that option very often. Everything else, if you're lower third, it's not getting blackballed. If you are unlikely to rank, that's kind of a blackball. And then there's the comment section. We're emergency medicine physicians. This is a short comment section, only 250 words or less, right? This part is more like a traditional letter of recommendation. It talks about your qualifications as an applicant. However, it says in the instructions we're supposed to talk about your weaknesses as well. In a traditional letter of recommendation, it only says good things, like you are very prompt and you could dress professionally. If you don't have any other good things to talk about, they're still going to talk about good things. Here we're talking about your strengths and your weaknesses. All right, so hopefully that is totally clear-cut at this point. So this sounds like a really great thing that we started in emergency medicine, and it is really, really helpful and much better than what other specialties use to try and rank applicants. However, it's not perfect. We tried to make something that's very standardized and very uniform, but it's impossible to be uniform. We do have residency programs and clerkships that are really different, and we can't make them exactly the same. There's different people who work at these institutions. When we all read the letters, we know that some people write glowing letters for almost everyone, and we know that other people are very blunt in their evaluations of people. We know some people are easy graders and some are not easy graders. The good thing is we all read the same letters over and over, and we know the letter writers, so we sort of know how to evaluate those things. And as I mentioned before, math is kind of hard, right? We all are your advocates, we're your advisors, we want you to do well, and it pains us to put people in the lower third, even though we know maybe the other 2/3 of applicants are a little better. We're working on, as a group of educators in emergency medicine, really understanding that lower third is not bad and that some people need to be in the lower third. That's because you guys are all awesome and you're really competitive. So your peers, the ones that we have to compare you to, are very strong students. So if you are told you're kind of in the middle third when you're going through your rotation, that is not bad. That means you are right where everyone else is, and everyone else is a really strong student who's really motivated and hardworking. If you're a lower third student, that is not meant to mean, again, that you do not, don't take this kid, he's lower third, a terrible applicant. It just means that you're good and not great. So if for some reason you hear lower third in regards to yourself, it's not a bad thing. All right, so we're going to go through the qualifications section in a little bit more detail. So the first thing that we're asked to evaluate you on is your commitment to emergency medicine. So you guys are all here. You probably have already established a lot of knowledge about the field, but it's important to understand what makes emergency medicine unique, what are the challenges facing emergency medicine. So do some homework before you do your away rotations on that. We talked a little bit about getting an away rotation. So if you really want to go to Southern California, that's like your goal, your end goal, and you get a rotation in Cincinnati, you need to be really excited about being in Cincinnati because, one, it's a great place. You're going to learn a lot of good things, but that lack of interest that you might otherwise have because it's not sunny Southern California is going to come across in the rotation. It's going to make you get lower third in this area. If you're not sure you want to do emergency medicine, that's okay, but that's a discussion you need to have with your advisor, not while you're on your rotation. Like, don't tell the student every shift, your resident every shift, like, I don't really know if I want to do this. This is definitely going to get you ranked lower in that area. The next one asks us to evaluate your work ethic and willingness to assume responsibility. So obviously, when you go to your rotations, work hard. Know what's going on with your patients, and if you don't have something that's directly related to your patient care to do, then try and help somebody else out. Maybe the respiratory therapist, you go offer to help them, and they teach you how to use BiPAP. So you'll get a lot out of it, and it'll really show us that you are someone who's willing to be part of the team and work hard. I know everyone has medical information on the phone. You're going to have MD Calc, you're going to have maybe a reference that you're reading, but when I see a student like sitting down looking at their phone, my first instinct is to think like they're on Instagram or they're texting or something like that. So try and keep that to a minimum, or if you are doing it, say like, hey, I am looking up the Nexus C-spine criteria. I'm not just sending email to my girlfriend. Don't hesitate to help with other patients. You'll have your patients that you're assigned to, but if you're not busy with those patients, you can see if your team needs you to do something else. That'll really help out and get you higher in this category. Next is your ability to justify a differential and treatment plan. Obviously, if you have a lot of baseline knowledge, that'll help you get up in this category, but be ready to explain your thought process. Whoever you're working with during that shift may want you to give a 1-minute presentation, so you don't have a lot of time to justify your thought process. But if you say, I want to order a CAT scan of this person's abdomen and pelvis, your reason for that should be better than because they have abdominal pain. Like, you should have something that you're looking for. If your plan is different from your attending's plan, that's fine, but ask some follow-up questions like, why did you want to get a D-dimer in this patient? I didn't think we needed one. And then listen to the answer and incorporate that into your next presentation. You probably already know this already, but generally don't limit yourself to a single diagnosis. So someone can very clearly have a viral URI, but at least in your differential, you need to say, I considered pneumonia, I considered an acute HIV infection, but I don't think that's what it is because of these things. All right, we're probably running short on time here. We'll finish up. So the next thing is your ability to work with a team. Emergency medicine is definitely a team sport. It's one of the things that I think makes it such a fun field to work in. So when you come in, you do have to introduce yourself to your attending and your resident, obviously. But if you're working in an area where you have like the same nurses and techs, and introduce yourself to all of them as well. They will then like you, they'll talk more about you to the attendings, like that's a really great student, that stuff totally comes back. And then they'll also find you to maybe show you, like, I'm going to show you how to put on a sugar tongue splint on this patient with a distal radius fracture. So it's good for you in your evaluation, and it's good for you in your learning. Different institutions, though, have very different rules for what students should do. So yeah, you may at your institution get to start IVs, and that's totally cool, but you go to a different place and students aren't supposed to start IVs until they get permission from someone. So don't just jump in and do someone else's job until you know that that's okay at that institution. The other thing is everyone wants to do procedures this time of year. The interns are brand new. They want to do the LP. You want to do the LP. The other visiting students want to do the LP. If it's your patient, it should be your procedure. But if it's a patient that's not clearly assigned, before you jump in and take the procedure, make sure it's not like someone else's. All right, so caring nature. Hopefully this one is really easy for you guys to get high points on. If you're a nice person, like show you're a nice person. It's okay. You don't have to like be that sort of like gruff ER doc who doesn't care about anyone. That's not really what we want to see. You have more time than your attending and your resident in general, so be your patient's advocate. Go back and check on them, go update them, figure out if they really understood what was going on when your resident said, we're going to get troponins and chest x-ray, and they're like, I don't even know what those things are. You can go back and explain it and help your patient feel a lot more comfortable. I get patients a turkey sandwich, a hot blanket, a pair of socks every single shift. So don't think that just because you're the sub-I, you're like too good to do those things. That really shows that you care about the patient. You're part of the team. You want to do what's best for the patient in regards to everyone else working in the emergency room. Hopefully a lot of that stuff was common sense. And you are doing this on your other rotations and excelling generally in medical school, but those are the important things that you need to do to get high rankings on your SLOE. Now, unfortunately, you cannot read your SLOE. It is something that you have to waive the right to see, like your other letters of recommendation. You can get some idea of what's going to be on your SLOE by asking for feedback, especially from the clerkship director. You should do that after a week or two of the rotation to get an idea of what you need to change so you can improve if you're not doing a great job already. And then you have to listen to what they say and incorporate that. So if someone tells you you're too quiet or you're too aggressive, you should not think like, they're wrong, like I'm totally fine. Obviously, you should take what they say and try and be a better rotator on that rotation. Any questions? Or do we have time for questions?
We'll take one.
Okay.
I think there's somebody, gentleman over here. We'll take one question, and just like before, we'll move on.
So in terms of letters of recommendations for applying in general, for emergency medicine, is it worth submitting, if you have two SLOEs, a letter of recommendation from like internal medicine that is clinically oriented, or are you better off submitting one or two from research or someone who can speak to other characteristics? Like, will those clinical letters really mean anything
So you have
in adjunct?
4 slots in ARIS to put in letters, so 2 have to be SLOEs. The other 2, I've heard people who review applicants, in different institutions say different things. Like, I don't even look at it if it's an internal medicine letter. My practice has been to read those. Core rotations like internal medicine, surgery, an ICU month, those, if you do well there and have a good letter, that means a lot to me. If you are doing like a outpatient neurology rotation, like that doesn't apply as much to emergency medicine and doesn't mean as much. Again, if you do a research, you do some research with someone who's worked with you for a 2-year period and says you came up with the idea, you did the IRB, you did everything, that's meaningful. If you just joined onto someone else's project and you really enrolled a lot of patients and that's kind of it, that's not as meaningful. So it varies.
Thank you.
So, and I totally agree. I told the ambassadors yesterday, a lot of those letters, your letter from internal medicine says, I worked with this student on the hospitalist service, and this is one of the finest students I ever worked with. They came early and they left late, and they took great care of patients. Their notes were great, and their presentations were wonderful. Signed doctor in internal medicine that no one from our specialty ever heard of. And that's what a lot of those letters look like. So I would just echo that a SLOE would definitely trump that. And I also have heard a lot of people say that they don't read them. But I think it is worthwhile to fill all 4 slots. So you have, use the bullets that are in your chamber to help you match. And you may get some program directors that look at that, and you may have some that don't. So great. Can we give a round of applause?